Hello, and welcome to our first discussion of antipsychotic drugs. We're going to begin our discussion with a little bit of a review about psychological diseases and disorders. It's important, of course, to understand when we're talking about treating psychological disorders with drugs that we have an understanding about what types of disorders we're talking about. First thing we need to understand about these kinds of drugs is there are some general principles to keep in mind. And the first is that drugs are not disease specific. That is, they're used to provide a benefit for specific symptoms. It's unlike a lot of other kinds of treatments that you might have thought about with other diseases. A chemotherapy drug is used to treat cancer. Antibiotics are used to treat bacteria. When it comes to treating psychological disorders, we treat the symptoms themselves. And the issue often becomes understanding what a psychological disorder is. And in fact, we're still very early in understanding the causes and the specific underlying physiology of these kinds of disorders. So we're usually treating the symptoms to try to make the person more functional in their behavior. And so keep that in mind. Important to understand, some patients do not respond favorably to any drugs. Sometimes it takes a while to find the right drug. And so as we talk about each of these specific kinds of drugs used to treat psychological disorders, it's oftentimes difficult to get the right one found. They do work when they are used correctly and when you can find the right drug for the right person. But these are not a panacea. That is, they're not they're not a perfect solution, despite what some of the commercials might say. All patients are at risk for side effects, and these drugs have some pretty significant side effects, particularly the antipsychotics we're going to be talking about. And that's really important to keep in mind. Now, of course, when it comes to treating a disease like schizophrenia, these are people who are deeply disturbed and are not going to be able to function without some kind of relief. And so you have to weigh the risks and benefits of treatment. And with schizophrenia, the risk is almost always in the direction of treatment. Now, of course, we cannot predict specific behavioral effects of a particular drug on a given patient. And a lot of this has to do with the issues we've talked about already. Genetics, different body types. People respond differentially to different drugs because they metabolize differently. They just have different effects in different people. And you've probably all seen this in the way drugs affect people that you know. Alcohol affects everyone a little bit differently. We know people who drink a little, have a great time, and go home. Others that start drinking and don't stop until they pass out, and others that just get mean and nasty when they drink. It's the same thing with antipsychotics. Some people respond very well, and some people don't. So it's important to understand that this is a very delicate and complicated issue that requires a lot of thoughtful understanding about the drugs themselves and a lot of patience. So we don't really know how the beneficial effect of these drugs is related to their physiological effects, and that sounds crazy, but it's true. Neuroscience, and particularly psychopharmacology, are relatively young fields. Now, of course, psychopharmacology really, in some sense, is thousands of years old. People have been using drugs to alter behavior for millennia. But understanding how these things work and how they function is a whole other problem. Later in the semester, when we get to talking about marijuana, it's never been clear until very recently why we have neuroreceptors that respond to THC. Doesn't make much sense until you start to realize that there are some beneficial effects of THC, which we'll talk about later on. So that's our first bit of introduction to some problems with those drugs. Next, I want to talk a little bit about the major categories of psychiatric disorders. And if you want to learn more about this, I highly recommend taking Abnormal Psychology if you haven't already. Whenever we talk about psychological disorders, primarily we're talking about diagnosis using what's called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. We are just now switching from DSM-4R to DSM-5. And DSM-5 will be coming out this year. In fact, they finally, I think, just now settled on what's going to be in the DSM-5. It's going to be very different from what's been in the past. I'm not an expert in that area, and I haven't even seen the new manual, so we won't talk much about that, but keep in mind that this is an evolving concept. On the international scale, this is what's called the ICD-9 or 10, I don't know what number we're on now, which is the International Classification for All Diseases. And so when we're talking about mental disorders and diseases, these are the diagnostic codes that are used to do things like bill Medicare or Medicaid. So it's an important question, but it's beyond our purview here. So keep in mind when we start talking about what are the symptoms of these diseases, we're talking in general because the experts themselves can't agree. So schizophrenia is the first major psychiatric disorder we're going to talk about. This is a very specific class of disorders, relatively clearly delineated from other disorders. It really does seem to be its own kind of beast, as it were, marked by very severe psychosis, hallucinations, auditory hallucinations, sometimes visual hallucinations. This is really the most significant mental disorder that we're going to talk about. It's really one of the reasons why we're starting here. Lots of really interesting things to look at with schizophrenia. If you're interested more, there's a great book called Surviving Schizophrenia. A Beautiful Mind is a great book, also a great movie. If you want to see a little bit inside what schizophrenia looks like. Really, it's fascinating, but also very, very hard to see in patients. We're going to talk about affective disorders, which are basically mood disorders, disruptions in emotions. Of course, the major affective disorder is depression. There are various kinds of depression. We'll talk about major depressive disorder. There's also dysthymia, which is a shorter or lighter version of major depression, but fairly easy to understand, but also sometimes very difficult to live with, and certainly something we want to talk more about. But that's not what we'll focus on today. Bipolar disorder we'll talk about after depression, which is a very difficult disorder to keep patients treated. We have pretty good drugs for treating this disorder. Excuse me. But it's oftentimes difficult to keep patients on medication. Bipolar disorder is marked by periods of manic and depression, where people are very high and very up and moving, and oftentimes are out for a couple of days, and then very, very deep depression. We'll talk a little bit about anxiety disorders and their treatment later on, and of course it's relatively straightforward. So let's start with trying to understand schizophrenia. And the first thing we have to understand is how do we go about diagnosing schizophrenia. Schizophrenia tends to have an onset in the late teens, early 20s, particularly in males, more common in males. The differential diagnosis is done through observing behavior. There's no test, no blood test, no brain scan we can use to definitively diagnose schizophrenia. It has to be done based on symptoms. So the core features here are at least 6 months in which there are prominent psychotic symptoms are present for at least once a week. Their psychosocial functioning is poor. They're not going to work. They're not taking care of themselves. Usually pretty easy to see. If mood disturbance is present, this tends to be very brief versus the psychotic symptoms, which tend to be much longer lasting. Now, the prominent psychotic symptoms involved in schizophrenia are content of thought disruptions or delusions, and these delusions can take on a variety of manifestations, including false beliefs. Oftentimes they believe they're being persecuted, or they're very paranoid. People are chasing them, they're after them, they're bugging their house. Lots of false beliefs. These are not amenable to change by reason or experience. That is, you can't talk people out of these delusions. They are delusional. There is also sometimes delusions of grandeur. Oh, I'm the President of the United States, or I've done all these really great, amazing things. There are also thought disruptions, and this tends to be what we call a loosening of association among thoughts. And this is marked primarily by, or it's easiest to see through, what we call this word salad, where you get people who talk in ways that just don't make any sense. And so it's fairly straightforward. I had a student once in a previous class at a different university who really felt that he wanted to engage with the class and felt like he had to ask a question or say something every class, which I thought was really great. But unfortunately, his questions never made any sense. It would be things like, well, my friend just got back from Iraq and the grass grows greener in California. So it didn't really make any sense. In his head, they apparently did. But what's happening is, because there is such a disruption in cognitive functioning, they're unable to string words together in a way that makes sense. There are also perceptual disturbances, which tend to take on the form of hallucinations. And a hallucination is just a perception that occurs in the absence of a stimulus. And these are usually auditory, and they're usually voices. They usually hear voices talking to them. Oftentimes, this is why you'll hear somebody say, well, God asked me to do X, Y, or Z, and it's never anything good. It's always drowning their children or shooting people. It's always awful. I don't mean to make light of that. But these hallucinations can be very dangerous. Now, usually they're not. But once in a while, they can take on a very, very sinister, problematic form. And so that's an important thing to try to get treated. The mood disruptions, or their affect, tends to be just flat. There's no emotional state or no reaction. So it's not that they're sad, it's not that they're happy, there's just nothing. Very flat affect, and you can't really see any outward expression of emotion, or it's abnormal. The response is inappropriate laughing, that sort of thing. Now, we'll classify symptoms of schizophrenia by positive and negative symptoms. And this is one of those weird areas in psychology. When we talk about positive, we're talking about the addition of something. It's kind of like positive reinforcement versus negative reinforcement. Positive reinforcement is the addition of something positive that's reinforcing. Negative reinforcement is the removal of something aversive. And so when we talk about positive, it's adding. Negative, it's taking away. So when we talk about positive symptoms, these are delusions, hallucinations, and these thought disorders. So this is taking a normal person and adding these bad things. The negative symptoms are those which have taken away something. Anhedonia, withdrawal, and affective wanting. And these are just, they aren't moving, they're withdrawn, and they have no affective response. And then finally, there's cognitive impairment. And this is where a great deal of research has gone into looking at the role of the frontal lobes in schizophrenia, because it's very clear that this part of the brain has a great deal of involvement in schizophrenia, because that's the part of the brain that's responsible for what we call our executive functions: working memory, our ability to project into the future, to manipulate information. All of that's done through our frontal lobes, and these are greatly disrupted in schizophrenia. So that's a very brief introduction to schizophrenia. Again, I urge you to take abnormal psychology if you want to learn more about any of the disorders we talk about in this course. Now, we're going to briefly, in this section, talk about the oldest classes of drugs and sort of where they come from, and how we got to where we are today. And one of the most significant advancements in the treatment of schizophrenia was the discovery of chlorpromazine, which is Thorazine. And this was the first drug that showed any effect in treating schizophrenia. In fact, up until the 1950s, 1960s, people with schizophrenia were simply locked away in asylums. There was nothing that could be done for them. And we've come really a long way, which is terrific. So, how did we get here? Well, it turned out there's a dose-response effect of antihistamines that suggested that drugs could be more specific than previously thought. That is, they might not be these general classes of drugs, but much more specific. And we now know, even with antihistamines, for example, that there are a great deal of specificity, and some antihistamines work well for some allergies and some don't for others. In fact, there are two different kinds of antihistamines. Drugs like Zantac, which we generally think of as treating GI disturbances, heartburn, that sort of thing, is actually an antihistamine. And in fact, they function to block a separate kind of histamine than do drugs like Zyrtec. And so it's something to keep in mind. We didn't have the kind of drug specificity we have now. So a group of folks led by Cavassier and his colleagues developed chlorpromazine. In 1950, a French Navy anesthesiologist thought antihistamines might be useful in preventing fatal effects of shock in soldiers. And this is, of course, at the beginning of what eventually became the Vietnam War. What we then end up with is the first demonstration of antipsychotic effects from this particular drug, because our Navy scientist reports unusual sedative properties of chlorpromazine. Even after major operations, patients were not excited, did not complain, and genuinely appeared to suffer less. So they gave chlorpromazine to two groups of psychiatrists and found that there was a calming effect. First led to treatment of manic patients, and then they discovered it was not specific for mania, but did calm psychotic symptoms. Mania is part of bipolar disorder and oftentimes is accompanied by psychotic symptoms. So then we get chlorpromazine marketed as Largeptil. SmithKline in French marketed as Thorazine, which of course are now GlaxoSmithKline. We then get the use of the term neuroleptic, which is coined from the Greek lepto, to make fine or delicate. And so it's essentially to reduce or to make more delicate neural functioning. And so neuroleptic is oftentimes used to describe a whole class of drugs like antipsychotics. So you'll hear me in your textbook use the term neuroleptic. That's what we're talking about. So finally, in 1956, we get an article in Psychiatric Services describing the revolutionary effect of chlorpromazine. And in fact, if you take a look at the effect on patient populations from the 1900s to almost 1960, right at 1956, we just simply get an ever-growing population of patients in public mental institutions. And then finally, once chlorpromazine or Thorazine is introduced, we get this dramatic reduction because it's so effective in treating patients that they're able to leave hospital and go back into the community. So this success then led to an intense search for more drugs that would relieve psychotic symptoms. So here we are now more than 60 years later. There's good news and bad news. There's good news. We have many drugs like chlorpromazine that can reduce some symptoms of schizophrenia. Unfortunately, there's still work to be done. These drugs can help everyone, and there's some question about whether or not those people who can't be helped might have a different kind of schizophrenia. Certainly not all symptoms are improved. For the most part, these drugs will affect those positive symptoms. They'll reduce the delusions and hallucinations and the thought disorders, but won't always affect things like mood. So there's that. And there are some very serious side effects, and we'll talk about those in our later discussion. So this new generation of antipsychotic drugs may help with at least some of these problems if we can figure out why. We might understand the cause of the illness better. And that's really one of the goals of research in psychopharmacology, is not just to treat the patient, but to also understand why does that treat the patient, and what is it about the disease that's making it, that this drug makes it better versus another drug. So essentially what we're trying to do is reverse engineer the cause of a disease by figuring out how we treat it. And that's an important thing to understand. It's how doctors oftentimes try to figure out whether you have a bacteria or a virus. They give you a whole slew of antibiotics. You don't get better. Oftentimes they say, well, you must have a virus. It's not very reassuring, but it is oftentimes how diagnosis is done. So what do these drugs do to schizophrenia symptoms? Well, oftentimes, initially, patients become very sleepy. This usually wears off in a few weeks. These are very powerful antihistamines, and any of you who have ever taken Benadryl will know the antihistamines tend to be very powerful in terms of making us sleepy. After a few weeks of treatment, that wears off. Patients no longer feel sleepy from being treated with these drugs. This is not the reason for the antipsychotic effect. It's simply a side effect. However, after a couple of weeks, symptoms do start to improve. They tend to stop hearing voices. They become less paranoid and less suspicious. Speech becomes more connected and coherent. They're able to take care of themselves, and they do tend to be a little bit more emotionally responsive. So it does a little bit affect some of those negative symptoms that we talked about. So these can be very important in helping to treat schizophrenia or other types of psychosis. And we're going to talk more about that in the coming lectures. We'll first talk about first-generation antipsychotics, which are things like chlorpromazine and related drugs. And then we'll go on to talk about what we call second-generation or atypical antipsychotics, and talk a little bit about these modern drugs and how they work and what their benefits versus problems are. So thank you, and we will talk next about first-generation antipsychotic drugs.